So, hello and good evening. Welcome to another EANS webinar series. And my name is Jürgen Beck. I'm the neurosurgeon director in Freiburg, Germany. And I'm really happy and proud to present you another webinar about really relevant and interesting topic about getting headaches from CSF disorders. And we have a world-renowned panel. We have Rigmor Jensen as a moderator. Rigmor is the head of the Danish Headache Center and a professor of neurology and a key opinion leader worldwide for all kinds of headache disorders. Then we have a panel of Susan Mollan, Georgios, Tsermoulas, Katharina Wolf, and Florian Volz, who are presenting from both spectrums of CSF disorders, from high pressure and from low pressure. And please do not hesitate to ask questions. And if you have questions, put them in the Q&A box. And we will go through all the questions at the end of the seminar and also in between. Don't put your questions in the chat box, put them in the Q&A box. So without further ado, we start with content. And Rigmor, I hand over to you. Thanks for joining.
Yes, good afternoon and good day, everybody. And it's a pleasure to be here and a pleasure to talk about these interesting types of headache because we can do so much for these patients. And the first speaker is Susan Mollan, professor honorary professor at University of Birmingham, Kingston and Birmingham in UK, and also research director in Canada, Ontario at Queen's University, and just started over there. But you have a long career in Birmingham and working with IIH, a very fascinating area, and a world-leading neuro-ophthalmologist. So Susan, please carry on. We're looking forward to your presentation.
Thank you very much, Rigmor. It's an absolute pleasure to be here. I do have some disclosures, but they don't relate particularly to headache. So really, the question here is don't ignore my headaches. We all deal in different parts of idiopathic intracranial hypertension, but often we forget to ask our patients about headache in clinic. We know that IIH is a condition of raised intracranial pressure that causes papilledema. It's a systemic metabolic disease. And while we're all here to safeguard the vision, over 90% of people get headaches, and headache treatments are really an unmet clinical need for our patients. We all understand the raised intracranial pressure phenotype that may have the following characteristics of being positional, being worse on Waitling, being aggravated by Valsalva maneuver. But as you look after these patients, you recognize that this really happens very early in the disease. And once the headache starts to escalate, these features may be dampened and you may lose them in the history. We know that the headache symptoms are similar when we look at the IIH treatment trial, the study performed by Professor Jensen in Copenhagen versus migraine controls. They get similar phenotypes and features. Unfortunately, the visual symptoms are also similar, which makes it really difficult to pick out whether the person's having a chronic migraine attack or whether they're actually having raised intracranial pressure. And the next thing that's more bothersome is all headache types can improve with lumbar puncture, albeit that patients with IIH more frequently get a temporary benefit from lumbar puncture, but also don't forget 1 in 4 migraineurs do as well. The burden of headache is really costly, not only in our patient group, but across society. And these are just some of the UK figures to show how many days are lost in work and how much it costs our economy. What we should do is think about treating the underlying disease. We know that weight management really works for these patients. We know that certain percentages of weight management loss work well. And in particular, I've picked out obstructive sleep apnea, which we're going to briefly talk on. So these patients need help being referred to weight management services as appropriate. And the reason for that is when we looked at our IIH weight randomized controlled trial, we showed that if we put the disease into remission, the headache severity got better, the headache frequency got better. As we saw, it was correlated with quality of life as well. So this would suggest that reducing ICP and having remission of the papilledema should mean there's a remission of the headache. But we all know that's just simply not the case. So we can't just treat headache with ICP treatments. We know there are many factors that push our patients over into having long-term chronic headaches, and these can be part of their family history or their concurrent diseases that include depression and anxiety, living with obesity and obstructive sleep apnea. The persistent post-IIH headache is particularly difficult to treat. So if we can screen for obstructive sleep apnea and treat obstructive sleep apnea, we know that it reduces headache. So this is the second referral to think about sending your patients to sleep specialists. The next thing we think about is preventing addiction. And I really mean this. I was quite surprised by our data that showed our patients were using opiates and simple analgesias 7 years out of their diagnosis. We need to address this condition called medication overuse, where patients use too many analgesics that contribute to that background headache. Medication overuse is particularly bothersome and is present in people with chronic daily headaches, and it makes treating headaches very difficult. So the third referral is about referral to neurology. And I know I've got my neurology colleagues on the panel here. We must start with primary care services. Primary care doctors and GPs are actually very good at treating headache. We think about the types of drugs that we may use that may be suitable in IIH, and some of the drugs that we may not be so suitable. So sometimes people that have had beta blockers exacerbate weight gain. It doesn't mean that you can't use this medicine, but you have to think about it. And as we go through, in certain countries, we either have 2 preventatives or 3 preventatives before we go to what I call the big guns. So these are the headache treatments that are new that our neurology colleagues help us prescribe, the CGRP therapies, Botox and GPANs. So as I highlighted there, we've got to think about those medicines that could exacerbate weight gain or cause alterations in mood. We've had some success using these CGRP treatments where we've shown in a group of chronic patients with IIH and headache that they get improved migraine days, improved monthly headache days, and they're returning to work. What I would caution, though, is if you treat the headache very effectively, but the patient gains weight, sometimes their disease can go out of remission. So it may well be that you need to escalate ophthalmic examinations such as OCT screening in patients that have very effective headache therapies. The things I would suggest to avoid in IIH headache: please avoid lumbar punctures. We know we need it for diagnosis, but our patients really respond very difficultly. They find it's a highly emotional experience, and you only get a very short-term therapeutic effect. In some of our data from Birmingham, we showed, looking at our patients that had CSF diversion, that actually you see the headache reduces there and reduces by 75% by 3 months. And this mirrors the institutional studies we see in the literature. However, by 12 months, that's climbing again to the pre-surgery rate. And you see it continues to climb as you follow those patients for long term. And the problem with the literature is most of the studies, the patients are not followed long term. So CSF surgery may give you a headache holiday for a bit, but it doesn't treat the patient in the long term. At the moment, there's no randomized controlled trials. We've got to think about the other problems if we were to consider shunting patients for headache. So we strongly recommend that if you're going to perform invasive procedure, that patients have been trialed on at least 3 or 4 preventative medicines at therapeutic doses for at least 3 months. There are many pitfalls for the neurosurgeon when we think about treating patients with headache. In the ophthalmology department, really ask your ophthalmologist, are those discs really swollen? Because they can have things like foams underneath their disc that elevate it to make it look like they're swollen. We really need to ask our neurology colleagues to help us. Have the patients really trialed 3 or more preventative medicines for enough time at therapeutic doses? And then you've got to think about yourself. I know you all want to help these patients, but there's a real lack of evidence for using surgery to treat headache in IIH. So my tips to take home is IH headache mimics all other different types of headache. We do need to put the disease into remission early because that helps with headache. We've got to think about obstructive sleep apnea. There are certain risks for chronic headaches that we can't really change about migraine biology and other comorbidities. I think we all have a duty to think about medication overuse because that's easy advice for our patients. But we should actively seek help for abortive therapies and preventative therapies, first through the primary care doctor and then through the neurology route as appropriate for your country. And please don't consider surgical intervention for headaches. It really does make the patients worse in the long term. So I think I've done my allotted time. I'll hand over back to the panel.
Thank you so much, Susan. Excellent overview. Any questions from the audience? I can't see any. So what do you recommend? Because we see these patients very late in the headache clinics, and they are already chronified. So and we also see many misdiagnoses. So what is the most important thing when you are in suspicion of an IIH in a young female?
I think that's really right, Rigmor. I mean, the misdiagnosis rate can be anywhere between 50 and 75%, and it's the incorrect diagnosis of papilledema and not following a diagnostic pathway. I think we're all clear that there's diagnostic criteria, and people need to follow that, because otherwise what we do is we kind of stigmatize our patients in assuming they have a condition called IIH. I think to the second part of what you said about patients turn up to the neurology clinic late with really chronic headache. And I think we can all engage our patients in getting their family doctors on board. I initially suggest to my patients about writing out headache diaries, writing letters as an ophthalmologist to the primary care doctor to direct them, say, these are migraine-like headaches, please treat them as migraine. I think when we say this is IIH headache, our GPs just don't know how to treat it. So if you use the term migraine-like and then suggest some medicines that may be helpful, I particularly find candesartan's quite a helpful drug in these women because it avoids some of the other issues, particularly if they have mental health problems or you're worried about precipitous weight gain when they've got active papilledema, and really helping the GP and saying the patient needs to escalate their dose and then be on that dose for at least 3 months before we can say that medicine isn't good. And then also the second thing is about getting the GP to actually prescribe abortive medications in the form of triptans.
Yeah, thanks a lot. There was some questions. Does the headache correlate to the ICP? Is there a clear correlation between these two?
No, so I mean, that's what the difficulty is in the literature. So if you take the IH treatment trial, they had acute patients, and you would have thought that their headache matched the ICP, but it didn't. When we looked in the IH weight trial, we had chronic patients, and actually headache over time correlated with ICP. So there's lots we don't know about ICP and how it causes headache. And I think one of the things that's interesting about IIH patients is 40% of them have a family history or a prior history of migraine, whereas in the general population, it's about 18%. So a lot of our patients are predetermined to probably have chronic headaches. So we don't see a great correlation, but we do know that if you treat it over time, the headache does get better.
Yeah. There was another question about was the position, and I can say yes, there is a clear positional relation that the patient wake up with this in the morning and or because of that the headache during the night. So that's clear in contrast to low pressure headaches. So there is a but when we see them very late, they it is more blurred, the presentation. You agree on that, Susan?
I absolutely agree. You really lose that sort of early morning awakening a headache as the headaches become more chronic. And as Rigmor alluded to, as we know from some of our studies in Birmingham and in other places, that the ICP rises as people are in bed at night.
Yeah. Okay. Thank you so much. More questions? No, I think we'll take this. Thanks a lot, Susan, and we're looking forward to further discussion later. So hang on. Jürgen?
Excellent, Susan. Excellent talk. Thank you so much. There was even the request for sharing your slides because they are so beautiful. Before I introduce the next speaker, since we have so many experts here, a very basic question from a neurosurgical point of view. What is causing the headache in high ICP?
It's for you, Susan.
Yeah, exactly. Thank you for passing that ball to me. So I think we do understand that ICP has a role in headache propagation. What we don't understand clearly is what happens to the ICP once the headache's underway. Again, I think Mr. Tsermoulas is going to talk a little bit about one of the studies that we've completed in Birmingham recently. He's nodding, which is the IA Provoke trial. So I'm going to take that ball and I'm going to pass it to Mr. Tsermoulas for his talk.
Very good maneuver. So that's the hint for me to introduce Georgios Tsermoulas. He's a consultant neurosurgeon, also in Birmingham, a professor of neurosurgery. He's also specializing in disorders of the CSF system, especially in idiopathic intracranial hypertension. Did a lot of studies and published many scientific papers about CSF disorders, and is now focusing on the surgical part, surgery for raised ICP. Georgios Tsermoulas, please.
Thank you very much, Jürgen. I'm delighted for the opportunity. I have no conflict of interest, and when we talk about CSF, we have to talk about intracranial pressure, and in physics, pressure is considered the force applied on the surface of the object per unit area, and there is different types of pressure, and in medicine, we talk about ICP as a differential pressure between the inside of the skull and the outside. And at sea level, the atmospheric pressure is 760 millimeters of mercury. That's the weight of the column of air that's applied on the head. And we consider a normal ICP in the supine position in adults a range between 7 to 15 millimeters of mercury. That is in the supine position. And I've got a poll question. I would be grateful for Andreas if he can share that question for the attendees to answer, please. What is the ICP of these people, normal, healthy individuals, standing in the queue? What do you think their ICP is while standing in the queue? -5, 0, 10 millimeters of mercury, 15, or 20 millimeters of mercury? What do you think the ICP of those people standing in the queue, healthy individual, is? Andreas, I'll leave it with you if you'd like to close the poll when most attendees have answered the question, please, and share the results. So in the supine position, we said is between 7 and 15 millimeters of mercury. What is in the standing position, a normal ICP? Andreas, can we please share the results? All right, so about half of you, 48%, said -5 to 0, and I would agree with this. This is the normal ICP in the standing position, and I'll show you the range that has been suggested on a systematic review by Marian Euler and Marek Czosnica. And these are what they call pseudo-healthy individuals because of course, it's not appropriate to ICP monitor or lumbar puncture healthy people. And in the upright position, the ICP is between -6 to around 8. And these are the other numbers. And it is important another important thing we need to realize is that the pressure generator is the mediastinum. so the heart is pumping blood into the intracranial cavity in a pulsatile fashion. And what I think is a useful analogy is that of a pebble in a pond. So every stroke volume with every systole is a little pebble in the CSF pond that generates intracranial pressure. And the height of the wave where the major intracranial arteries enter the skull, that is the carotid and the vertebral, is higher, and as the wave propagates, it wears off. So in the supine position, the mean intracranial pressure is the same both in the lumbar thicca and in the head, but the pulsatile pressure is higher in the head and lower in the lumbar thicca, and that's an important distinction to make. The two components of the ICP, the mean and the pulsatile component, that's relevant to headaches, and I'll mention why in a bit. Headache is a very common symptom, very many phenotypes, and in the context of CSF, it's caused due to high pressure and due to low pressure that my colleagues will mention later. And we did a systematic review that we have presented recently and meta-analysis on surgery for IIH in adults, about 100 patients, and headache, which is the most disabling symptom of this condition, improves following shunting, standing, and optic nerve sheath fenestration. And there is no real difference, no real statistical difference. But bear in mind that these studies, most of these studies, are small series, retrospective studies, and you cannot really get conclusive results from those. And Professor Mollan mentioned that, but I think it's important for us neurosurgeons to understand, and that's why I'm putting it up again, that shunting in IIH is for vision-threatening papilledema, and the papilledema, as you see on this graph, resolves. It goes to resolves at about 3 months, and the headache also improves, but for a short period of time. At 1 year, the headache is back to what is at the baseline, even with a functioning shunt. So a shunt is not a good treatment for headache, despite reports in the literature that shunt for headache or for intractable headache. The issue is, and irrespective of those numbers, the issue is that the severity of headache always recurs. At 1 year, at 3 years, it's back to what it was before. And the problem with these studies is that there's no long-term follow-up. And in the UK, in Birmingham, we lead on a multi-center UK trial on shunt versus stent for vision-threatening papilledema in IIH. And headache is one of the secondary outcomes. So we look prospectively at the headache, and we're aiming to recruit 80 participants. And so far, we have recruited 55, and we're delighted with the progress, because similar trials in the States and in France have stopped due to low recruitment. And we run a trial, a human physiology trial, to ascertain what is the link between intracranial pressure and headache. And we used the people with IIH and an implantable telemetric sensor as the human model. So 17 people with IIH and a telemetric sensor. And the primary endpoint, it was a placebo-controlled trial. The primary endpoint was a change in ICP after infusion of vasodilator peptide and during a provoked headache. And what we found, the orange line is the placebo and the blue line is the CGRP, that CGRP, which causes headache, does not increase the intracranial pressure, but the mean intracranial pressure, but for about 20 minutes, it increased the CSF amplitude. And this reached statistical significance. So a vasodilator peptide that caused headache did not increase the mean ICP, but it did increase the intracranial pressure. So in response to the previous question, the mean ICP may not be that relevant in the pathogenesis of headache, as is the ICP amplitude. So one of the theories may be that the dural nociceptors are not that sensitive to a raised ICP, especially if it's a chronically raised ICP. If you have a shunt malfunction and the ICP rises significantly over a short period of time, that causes headache because the change in the ICP, in the mean ICP, is high. But if it's a kind of a slow, gradual process, then the CSF amplitude, the raised CSF amplitude, may be the trigger for the dural nociceptors. Now, I mentioned that CSF disorder cause headaches when the pressure is high or low, but in carry-on malformation, there is no CSF pressure gradient between the intracranial and the intraspinal compartment. Actually, it's a mismatch between a small posterior cranial fossa and a normally developed cerebellum, but there is no CSF pressure gradient. And one of the typical features of carry-on malformation is headache. And there is two types of headaches, the so-called CSF pressure dissociation headache, also known as a cuff headache, because when we cough, a volume of CSF shoots up from the spinal subarachnoid space to the head, and in the state of normal, the CSF dissipates down to the spinal subarachnoid space once we stop the Valsalva maneuver. But in the case of a carry-on malformation, the cerebellar tonsils act as a valve mechanism, and there is raised ICP for a period of time that may be a few seconds to a minute or so, and these people have headaches. But another mechanism may be the obstruction of the foramen magnum, which impacts on the dissipation of the CSF pressure wave that originates in the skull base. And there have been studies that showed that in carry-on malformation, the mean ICP may be normal, but the ICP amplitude is elevated. And this is because the CSF pressure wave does not propagate normally. And then maybe a second mechanism that is causing the headache and all the other non-specific symptoms in this condition. In the UK, we've run the so-called CARRY-1 study. It's an observational study to look at the quality of life in people with CARRY-1 malformation. And we've recently published the first part of the trial on people that presented to neurosurgery and then followed up a year later without having surgery. And we have demonstrated that in all domains of a health-related quality of life questionnaire, it has not changed, it has not deteriorated. And the study on the operative measurement of carry malformation will follow. And I'll stop it there. Thank you very much.
Thank you so much, Georgios, for this very brief and concise and focused introduction about headache and CSF mechanism in hypertension. But I would like to start with the first question, chronicity. You've mentioned it. I think probably sudden changes or changes over the day are more related, at least from my basic experience, to headache rather chronic changes. So like we later see in intracranial hypotension when you stand up, orthostasis, or in hypertension when you bend over, probably these acute changes are more relevant than the baseline. Is that true or not?
Yeah, that's my impression as well. I think we're starting to understand the role of positional ICP, the role of amplitude in the pathogenesis of headache. And when there is sudden changes in ICP outside the range of normal, then that's probably a trigger for headache, both in a high and a low pressure state.
And congratulations to your excellent study and the excellent concept that you use patients with an implanted pressure device and to look for events during the day and relate them to headache. This is brilliant. But your numbers are against the notion that the pressure should rise or lower. There is no change, but the amplitude is going up. This is counterintuitive, isn't it?
I think that this goes to show that probably it's not the mean. I mean, there is a correlation between mean ICP and amplitude, and when the mean ICP rises, the amplitude rises as well. But I don't think this happens in all states, and sometimes the mean ICP may be within a normal range, and the amplitude may rise first, and maybe it is the amplitude that triggers headache, the raised amplitude, rather than the raised ICP. But I think more research is required to that effect.
Yeah, but it's really an excellent concept. There's one question from Professor Sofia Josnica to you. Is stenting able to help with headache?
That's a very good question, and there is actually prospective studies on stenting in IIH, and they have shown that the papilledema improves, the vision improves, and also the headache improves to an extent. But bear in mind that in the acute phase, the stent may cause irritation of the trigeminal innervated dura at the transverse sinus, and may cause exacerbation of the headache. And this headache may be severe in the acute phase in the first few days. But again, I don't think that stenting for headache is a good option in IIH. And there are trials that will look into the headache phenotype, including our trial in the UK, but also there is a trial in France, a so-called dive-in trial, that will look into stenting for IIH, and I think we'll have an answer shortly in the next few years.
But again, here it's important to emphasize that stenting and other surgical procedures, along with Susan Mollan's message, is for the vision and the vision threat, and in the early phases, not for the headache, because those studies that have been done are in the long term for headache, and it's not a good idea for that. And if they didn't have headache before, many of them develop afterwards. So I totally agree that it's only for the vision that we have to work here and be aware of the correct diagnosis. Yeah.
Why are you so strict on that and repeating that over and over again? Just to be a little bit provocative, shunting reduces headache 75%. It's huge in a pain disorder, and it lasts for 3 years. And shunting does not save all vision in all patients. It only lasts for a certain amount of time, and even with shunting, some patients get blind. So why are you so strict in telling us again and again, no shunting for headache? It works 3 years.
Have you followed them for 3 years? Very few studies, actually. So what do you say, Susan?
I was going to say, because they all end up in our clinics, not yours. And we have to deal with the complications and the abdominal complications. Now the migraine-specific medicines are superb medicines with very little sort of side effects and are very effective. And so, you know, doing surgery versus appropriate medical management is where we should be heading. And I think the studies that we see, it's a binary, as George was saying, headache, no headache. What they do in the migraine medicine studies is carefully phenotype that headache in terms of severity and frequency, and also cost to the person in quality of life. So I think we should be thinking medicines first, not surgeries. And
underlying causes the weight loss. Yeah, because it's symptomatic treatment. That's why we are so, and we have a recent study that only 2 to 3% of all IIH patients really need surgery, and that's because of the visual threat. So we need to dig deeper and understand what is going on, and that's where we are at the moment, and that's the most important thing in from our side.
Okay, I agree. It's a symptomatic treatment.
Yeah.
So thanks for the discussion, and I think we can continue later on, and we move to the next talks. And Rigmor, you have the pleasure to introduce the next speaker.
Yes, a great pleasure to switch to the low pressure part, and Dr. Katharina Wolf, working in Freiburg, is a neurologist, but with a great interest in headache disorders and a huge experience, and have worked a lot on this and is a leading expert in low pressure headaches. So such a pleasure to give the talk to you, Katarina. The floor is yours.
Thank you very much. And thank you for the opportunity to present on SIH, so Spontaneous Intracranial Hypotension. I will a little bit introduce the clinical spectrum and point out a refresher on diagnostics, since this is still a rare underdiagnosed disease, and then talk about like what we can do about headaches resulting from SIH, so pretty much what the neurologists can do, followed then later by Florian about the interventional treatment. This is where we are currently sitting, and this is our hospital where we have the CSF center and treat IIH, so hypertension, low pressure syndromes, normal pressure, hydrocephalus, and so on. And we try to understand, like as Georgios was introducing, what is causing symptoms, how are they related to the CSF dynamics, and how is this related to brain health. Let's switch to spontaneous intracranial hypotension. The actual cause of it is spontaneous spinal CSF leak. So CSF is oozing out at the level of the spine, and that causes traction to the meninges. It causes sagging of the brain, usually some dilation of the venous system, and even subdural hematoma, subdural hygroma. And all those results of the sagging are thought to cause the headache syndrome, although we by now know, similar as in IIH, that we have a very distinct symptom at the beginning, and after that the signs and the changes in the brain imaging, they resolve, they might be even normal, despite the ongoing syndrome. So we have a discrepancy here between the imaging and the symptoms. We have an incidence that's much higher than many people think. It's 4 in 100,000. This is as often as you can see subarachnoid hemorrhage. And if you think about your clinic, how often do you see subarachnoid hemorrhage? You should see as many SIH patients. It mainly affects female patients in the average, and mainly working patients. So it affects all the working population with a respective socioeconomic impact. It can affect elderly as well as children, but this is less common. If we talk about SIH, we always have to keep in mind that the literature, the evidence of this is very low. So this is what it has been published by 2025 on SIH, and on subarachnoid hemorrhage that's what we look into. So we always have to keep in mind that everything we talk is mainly expert-based and based on retrospective data. The syndrome is a mainly orthostatic headache, meaning that the headache appears or gets much worse when the patient stands up or is in upright position. But we know that there are a lot of other accompanying symptoms that affect the vestibular function, visual function, cognitive function, and also dysautonomia. There are two important things. It's usually a new headache, and the patient can, in most of the cases, 75%, can tell us the date of the beginning. So new daily persistent headache is a huge differential to this headache presentation, as well as migraine. It's often mistaken as migraine because the patient tells us about the need of laying down. So we have to keep in mind that over time, symptoms change, and that we have an inter-individual variability of symptoms. So there is even patients without orthostatic headache. So it's not excluding the syndrome of SIH, but the new orthostatic headache with a sudden begin is something that can give you the hint. We as neurologists, we need to think about fluid dynamics. So having different phenotypes over type, that we have a change in symptom severity or the most severe symptom being present to the patient even within a day. So we need to step back from sticking to certain syndromes and asking for that to be present all the time. We need to adapt to the fluid dynamics and the change in symptoms. Two very important things about criteria. The criteria currently tell us that the patients should have low opening pressure in the CSF loss diseases, and as is not true, we know this, so don't do lumbar puncture to diagnose this disease. And it requires positive brain imaging or positive spine imaging. For most of the spontaneous intracranial hypotension cases, this is true. For most of them, you can see positive imaging, but not for all. And for most postural puncture headache, it's just not true. You usually don't see any sign of CSF loss. So let's summarize this part. You need to go back and ask the patient, how did your symptoms start and how have they been initially? And then you can pick up on this orthostatic symptom and get the idea of SIH. It's very important to talk about the consequences of SIH. It's not a benign disease. Up to 40% develop chronic subdural hematoma, typically bilateral. You can develop sinus venous thrombosis in up to even 2%. And superficial pseudosis is a long-term sequelae that patients develop over the course of the disease, and estimates go up to 15% over 10 years, even higher numbers. Some refresher about the diagnosis. You need to perform MRI with contrast, and then you measure distances, the suprasellar distance, the prepontine distance, and the mammalopontine distance, and you look at engorgement of the veins, you look at the meningeal enhancement, and you look at fluid collection, and then you add up a sum score, and then you can estimate the likelihood of SIH, yet keeping in mind that over time those signs can resolve. This is some example. On the right, it's very severe, where it's just you don't need to measure. You see that there is even brain herniation. But on the left side, there's a full-blown burn score of 9, where you can see that sometimes you need to get used to looking at those images, and measuring helps. Then you should do spinal imaging with water-sensitive sequences, so you can pick up on dural tears. Here you can see the epidural fluid coming out, so this is proof of a dural tear. Even if the head is negative, with the spine imaging, you can pick up on many types of leaks. About the types of leaks, most of the types are ventral leaks. Most common in the upper thoracic spine is where you have a dural tear at the ventral side of the spinal canal. Then we have lateral tears, where we have a dural tear at the level of the nerve axilla, usually in the lower thoracic spine. And an increasing number of CSF venous fistula have been depicted in the last years. Then that's not because they haven't been there, just because diagnostics get better. And this is a malconnection of a vein, of the draining vein, directly to the CSF level. And this is mostly also found in the lower thoracic and upper lumbar spine. Then there is about 5%, there are sacral leaks, where you can find epidural fluids or dural tears again at the sacrum. One important thing, sometimes fluid collection in the upper cervical spine is mistaken as a sign of a leak. This is a false localizing sign. And just to mention this, we very, very rarely see leaks at the cervical spine at all, and very rarely at the lower lumbar spine. To find leaks, you need to perform dynamic myelogram. You need to have a trained radiologist, and they need to take care about the specific positioning and the timing of the myelogram. It's not a conventional myelogram that you need to perform in order to find the leak. So to wrap up this, for diagnostic, basic diagnostic, you perform MRI of the head with gadolinium, you perform water-sensitive MRI of the spine, and in order to find and localize the leak, you need to perform dynamic DSM or CT myelogram by a trained and skilled radiologist. It's very rater dependent whether you find a leak, and it depends on many techniques, so you should send the radiologist to a center to be trained. Now about the main part, about the headaches. What can we do about those symptoms that SIH cause? In most of the guidelines, you find rest, drink, wait. There is little evidence about this, and just a few studies have looked into this, and they state that within 2 months of resting, it can improve symptoms in 25%. So this is clearly not enough. You can treat with caffeine and theophylline. There is a meta-analysis for postural puncture headache, which is closely related in terms of the syndrome. And there seems to be some effect of that, although we need to keep in mind that there is a conflicting evidence about caffeine, what it actually does. But in the prolonged consumption, it's likely increasing CSF production, and we know from clinical observation that it works. Also, gabapentin is an option for prevention and pain treatment, as well as greater occipital nerve blocks and sphenopalatine ganglion blocks. And especially the greater occipital nerve blocks, they have now gotten raised awareness in other headache therapies as well, not only cluster headaches, but it just came up for acute therapy of migraine in the emergency setting. So this is just basic headache management, and it can be worthwhile in those patients. Also, symptomatic treatment, and I specifically put this in symptomatic treatment, it's very important to perform a lumbar blood patch. That's the first and easiest thing and most effective thing from all the symptomatic treatments we can do. So most patients improve, and there's even long time improvement after lumbar epidural blood patching. But what happens is actually a reduction of compliance, you increase pressure, but in most of the patients, it's not healing the patient, and that's important to keep in mind. Here you see a video of a CT, fluoroscopy-guided blood patching that our radiologists perform in our center. And again, you need to follow up what you do. Usually the blood patch is not healing the patient, but essentially improving the patient. So following up whatever you do is very important. Again, this is the overview on how to find a leak. The targeted treatment can be targeted patching, transvenous embolization for CSF venous fistula, and surgery is most effective for all the dural tears. That's what we know by now, and where the neurology just needs to pass and see that. And again, after the treatment, there are a couple of things we can take care about. So rebound hypertension. So after we close a leak or treat with epidural blood patching, it could be a usually transitory phase of hypertension that can be treated with acetaminophen. If it continues, we need to go down the road and think, okay, there is maybe some underlying cause of hypertension, IIH, and other secondary causes, and do the appropriate workup. Usually we don't do lumbar puncture in those cases. And again, as Susan has told us, we do have an overlap to primary headaches here as well, and rarely medication overuse. And having this in mind guides us through some more supportive treatment, looking for the phenotype and treating it accordingly. And this I will just skip a little bit because Susan has covered this. It's very important to keep general pain therapy in mind, not just putting a patient on continued opioids or non-steroid pain medication, but maybe talk to neurologists and see how we can solve chronic pain, adapt pain modulation therapies, go into these targeted therapies and molecular therapies, CGRP targets. There are now many treatment options out there, Botox, that can essentially help those patients. Again, we need to follow up on our imaging even if the patient is not symptomatic anymore, because it's not a benign disease. To sum up, it's very important to think about the symptoms, or go back, ask about the beginning, having in mind that it can affect all gender and ages, and finding a leak is most importantly includes doing a proper MRI of the brain and the spine, and start a treatment, but then follow up, team up, find the leak and close the leak. With that, I would like to thank our team here in Freiburg and thank the audience. If you want to keep in contact, you can follow those QR codes. And thank you very much.
Thank you, Katarina. Excellent overview of a difficult topic. So what we are always talking about, where were these patients 10 years, 20 years ago? Where were they? And what were they classified as?
Probably if you go back into your Danish headache center itinerary, you probably might tell us. Or I think, or maybe Professor Beck can tell more about this. I think, like, if we look in our numbers, we just see that they have been there. If we go out, if we teach and talk about it, all of a sudden 2 weeks later, the neurologists refer us perfect SIH cases who thought they be ultra rare. And yet we go to conferences and talk about this and see widespread eyes. So I think having this and talking about this is one of the most important things.
I totally agree. Comments? I didn't see any questions in the chat. Anybody else? So,
may I ask the question, Rigmor?
Yeah.
Yes. Now the topic that surgery doesn't help for headache, and headache is probably only a general symptom, and I disagree a little bit again, and I have a very specific, highly specific phenomenon before and after surgery. Before surgery, in low ICP, we have a clear headache pattern, orthostatic, probably in the back of your head, in the neck. And after surgery, not in all patients, but in many, and in the initial hours after surgery, there's a super clear, straightforward, stereotypic change in headache. It's suddenly now in the eyes, at the upper row of the teeth and the forehead, and completely different. So it's rather specific and has something to do with the change in ICP. Would you like to comment or?
Yeah, interesting observation. But we see exactly the same. So it must be the interaction between the trigeminal neurovascular system and also this cervicus complex that really, why is it much more challenged in the low pressure headache? So it is the pain sensitive area is so different, and you really change it so quickly. We see exactly the same when we do a blood patch, and that they just come up. So I think it's the whole trigeminal vascular system, and that changed so fast like that after surgery. But I'm not sure anybody else have any idea. Do you, Susan or Katarina? You have a good idea?
I actually liked Georgios' idea about the amplitudes.
The amplitude.
I think there's much more we don't understand. It's not just pressure; it's the difference in and the differential pressure also between the spine and the compliance of the spine, and how it acts as a wind castle phenomenon, or like how it can adapt to the change within the capitans. And I think that since we interfere with that, and that's probably going to relate to amplitudes again, and how to accommodate for those volume changes. I really liked, I think it fits very well what you showed from your results to other results that have been published and what we can observe.
And we see that there's also change in the animal model. When we increase the ICP, we can also see the change in amplitude. So it's absolutely in line, but it's difficult to ask the rat where the headache is located, where the pain is located. But we can see that exactly the same amplitude, as pressure is more or less the same. Susan, you have a comment?
No, not over and above what's been said, but I think the characterization of these headaches, the multi-omics research that's going on both in your center and in your center, Jörn, will really help us understand why we get these big shifts.
Yeah. Very interesting. There is one question or one comment from the audience. By the way, I do not know where all the SIH patients have been the last decades, but there is one comment from Croatia. After just one talk about SIH in my department, 3 patients were referred in 2 weeks. So it's real, and it's there, and it will not disappear again.
Yeah. We have 1 to 2 per week, and we didn't have that before. So it is also awareness and a much better diagnostics. Thanks to your work, all your work. Thanks a lot.
Just to make one last comment about where these patients were. I think some of them had undergone craniovertebral decompression for cardio and malformation, and we've seen the results. I have come to see the results later on And these patients do not thank the neurosurgeons who have decompressed the posterior cranial fossa, unfortunately.
There was a question more. I missed that. That was the one. Wasn't there another question?
Yes, there's another question from Sofia Chosnika. Do you recommend bed rest after lumbar puncture? And if, how long?
Katarina?
I think now we need to do a poll. I just know that, of course, our guidelines, they recommend bed rest of 1 hour in Germany, but I also know that data is very conflicting about this. There is some southern German data telling you need to rest on your belly to relieve the pressure. Most I know they rest on the supine position, and to be honest, in my practice, I ask them whether they are good, and then I get them going because otherwise they have lumbar pain.
Yeah. We agree, and very good question. We in the acute diagnostic LPs, we recommend 1 to 2 hours. That's all. But in the chronic ones, low pressure headaches, where we use more on, we recommend 24 hours. But it is very arbitrary, and maybe it's completely wrong because they also develop back pain. Yeah. Right.
So excellent. I would suggest now to continue with the last talk. Okay, good for you. So yeah, thanks for the talk. And now we have the same subject, but from a surgical perspective. Florian Volz is a consultant in the neurosurgical team in Freiburg and fully trained as a spine and brain surgeon. But since a couple of years, he added a new and is actually leading a new focus area, which is spinal leaks. And he's doing his PhD thesis for that and has actually operated hundreds of patients. So it's probably one of the most experienced surgeons for spinal CSF leaks. And I'm looking for his talk now. Please, stage is yours.
Okay, thank you, everybody. I'm glad to wrap it up. Can you see my slides? Can I see a thumbs up? Okay, thank you. My name is Florian Volz. I'm a consultant, and I actually at the moment I'm just doing leak surgery. I have no disclosures except that I'm a neurosurgeon and I like to do minimal invasive stuff. So I'm now very happy that I can present to you a topic where surgery actually helps for headaches, and I would rather aggressively advocate for doing surgery in SIH. You've seen those pictures. I just want to point out that these are the 3 main type of leaks, but the important part of the picture of the slide are these brilliant pictures. So what you need if you want to treat spontaneous intracranial hypotension, you need to be a good friend with your radiologist, because at the end, he's the guy that tells you where to cut. So me as a surgeon, I can cut everywhere, but I need a brilliant team behind our R. In our case, that's Horst Urbach and Niklas Lützen and their team, because they tell me where to cut. Without them, you are not a good, you can be a good surgeon, but you will be not a successful surgeon. What I want to stress from a surgical point of view, whatever you do in SIH surgery, it's not a trophy hunt. You do the approach that you feel comfortable with. If you want to do monitoring, then just do it. You don't have to do small approaches or minimal invasive approaches. You do whatever you feel comfortable with and what you used to do beforehand. Next thing I want to stress, it's not a treasure hunt. You have to be 100% sure where to cut. It's not an option to look for the leak somewhere in the spine. And this is why I like the minimal invasive surgery, because it gives me a kind of a special mindset. I have a small tube, but at the end of my tube, there must be my target. So it's for me, it's rather comforting to put my tube where I know where the leak has to be. What we do in surgery, this is the basic stuff for the ventral leaks, where we do the dorsal approach and we do a transdural removal of the spur after cutting the dentate ligament, pulling the leak out into my side, then putting some Tacosil inside, outside and inside, and thus labeling it the sandwich patching technique. I can show you a quick video, but at the end I will rather skip the operative part for time's sake. This is just how to give you an impression. This is the tube. This is the leak. We don't pull the spinal cords away. We pull the leak to our side. We remove the spur. This is the tiny microspur. We put the Tacocil from extradurally inside. And just for good measure, we put a Tacocil from the inside as well. So this is how we close the standard ventral leaks. This is surgery we now do almost every day. It takes us around 70 minutes for one case. I can skip that video because what I want to talk about and what I should talk about, that SIH is more than a leak. Don't you worry, I don't check all the boxes here. I have to talk about headaches. So we start with the headaches. And why do we have to talk about headaches in SIH? Because almost all patients have something with headaches. Only 1% have no headaches at all. So we have to address the headaches with our surgery or our treatment. These are the results from our surgical cases when we started out. Preoperative, this HIT6 score that I'm sure that you all know, these numbers are way too high. They are way above the threshold of 50 points that we have to reach because this means little or no impact. After surgery, after 14 days, not such a big difference, but after 3 months, there's a significant improvement. And this stays in the long run constant. So we can help the patients with their SIH-related headaches. So this slide is the success slide. This slide is the slide from the same population where I have to stress that the success, it's there, but it's not 100%. Preoperative patients that are severely affected, I mean, it's over 3/4. But 12 months after surgery, there is still 1/4 of patients that had a severe impact of headaches. So we did not cure them all. We have to look what is in this 25% of patients. Why did we not cure them? Is the leak still open? I mean, we can check. We do follow-up MRI in all of the patients. You have to check as a surgeon that you did your job and that you closed the leak. Did they have a new pathology? Is it central sensitization? I don't go into that. I'm just a simple-minded surgeon. I know in the panel there are people that know a lot more about that than I do. Is it the rebound hypertension? Because the HIT6 score, it's not specific. Maybe these 25% of patients are suffering now from rebound hypertension. What I want to close, we can, or you can operate on SIH and you help them with the headaches, but there is still 25% of patients that are still not happy. This slide is just, I sometimes show that to neurologists. Preoperative, high HIT6 score above the severe impact line. Postoperative, we almost reach for all of the patients the 50 yards line. So we make a difference of 15 HIT6 points, just we as surgeons with a 1 hour procedure. If you want to get a lot of funding for migraine studies or tension time, so the clinical relevant changes are 6 or 8 points respectively. So we can do something important for the SIH headache. But I told you, SIH is more than a leak. We are talking depressive symptoms. I'm not allowed to call it depression because I'm not a psychiatrist, but a lot of those patients have preoperative scores in this score, which is kind of a marker or screener for depression. Preoperatively, they have depressive scores. And after the operation, those scores drop immense. This is preoperatively. Almost 2/3 of patients are over the limit of clinical relevant depression. And here it's again the same 25% that are still suffering from depression. Could this be because this is a normal collective? No. These are the numbers for Germany in general. So they are still affected from depressive symptoms, just SIH related. One more thing, we are talking quality of life in general. And the numbers are exactly the same like the pictures I've showed you before. Preoperative, a VAS score like this basic score, 100 is the best, 0 is the worst imaginable health. So preoperative, we're around 40. But what's the average in Germany? It's above here. It's around 90. So we're half of that from the average. And these are just some numbers in certain types of cancers. So the patients with SIH, they have a completely messed up quality of life. But again, we as surgeons, we can help them. So after 6 months after surgery, we're almost back to normal, to the normal average in Germany. Last thing I want to check, it's the social implications. This is what Susan Mollan so brilliantly pointed out for IIH. These are the numbers for SIH that Katharina showed you before. It's exactly the same like subarachnoidal hemorrhage. This equals around 3,000 new patients every year in Germany. Is it relevant? Because yes, it's relevant. These are the old 10-year-old numbers from Wouter Schiewing. It's almost all of the time healthy people that are completely capable of working beforehand. These are our own numbers that are currently under revision. So it's more than 200 patients before SIH. They were all capable of working 100%. Some of them voluntarily reduced their working just for personal reasons, like taking care of their child, but they could work 100%. After the onset of SIH symptoms, 96 could not perform as before, and more than half of them were completely not able to work anymore. And this has huge socioeconomic implications. At the last follow-up, which was around 6 months after surgery, most of them could go back to work 100%. So we are not treating headaches, we are not only treating quality of life, we are not only treating depressive symptoms, we are making a socioeconomic impact because these patients can go back to work after our surgery. So it is more than a leak and it is more than headaches. This is our brilliant team, a lot of people involved in that. And this is my last slide where I want to invite you to our 3rd joint SIH Congress in Bern in May next year. So thank you for your attention.
Thank you so much, Florian. Excellent presentation. And I'm really fascinating about this disorder because we can do so much. And that's what we really want to do, both as surgeons, but also as neurologists. We can find these patients and we should find them and we can refer them to you and to our radiologists, but it's a team effort. It's really a team effort, as you mentioned. If we do not have a good radiologist, we cannot find them, and that's probably the issue in many cases. They have the patients, but they haven't identified them, and as such they can't refer them. But it's a fascinating area, and we can learn so much about physiology, CSF physiology, as Georgios said. And there's so much more to learn. Questions in the chat? You have the access, Jürgen?
Yes, and thanks for the excellent talk. And there is a burning question. 2 people ask, when the patient is already diagnosed with subdural hematoma bilaterally because of SIH, what should be treated first? Because they usually get worse clinically if you don't treat the SIH first, ? Is there any correlation? And there's another question from another visitor. I cannot read the name, but in very bold letters, in case of SIH and chronic subdural hematoma, would you go for a Burhole? ?
Can I answer that? So in our department, it's quite clear. If the hematoma is symptomatic, so if the patient has a neurological deficit, then you treat the hematoma. You completely disregard your suspicion for SIH. You treat the chronic subdural like in the old times where we did not know about the connection between SIH and the chronic subdural. If the patient is symptomatic from the hematoma, if the hematoma is asymptomatic and only a sign of the SIH, like a mark in your burn score, and you feel comfortable that you can diagnose and find the spinal leak in a timely manner because you have an experienced team and the patient is asymptomatic from the subdural, so no deficit, you can go finding and closing the leak. we try to establish like a rule of thumb of the diameter of the hematoma. And just because it's an easy number, we coined 10 millimeters in coronal views, where under 10 millimeters, it seems safe to go spinal first and chronic subdural after, if you have to treat it at all. If it's bigger than 10 millimeters, and especially if it's symptomatic, you go subdural first, and after that, you remember that you have to look for a spinal leak, but you can't treat it afterwards.
Excellent. I might add one little item that wonderful. We try to do leak first in small and CSTH first in larger ones. If you have chronic bilateral, please do not remove the drains all of the day and do not withdraw a lot of CSF. The suspicion is high, and probably the old rule, head above bed, is also keep them flat. And the risk, if you have a recurrence, look for the leak. Do not only look for MMA. If you have a recurrent chronic subdural hematoma, nowadays many people say, oh, you have to embolize the MMA. But if it's bilateral, look for the leak. There's another question from the audience, from Alberto Felletti. In case of CSF venous fistulas, surgery is recommended to close it. But in rare cases, if a patient comes with multiple fistulas and bilateral, what would you recommend? Would you recommend the blood patch as first choice, or what else?
So if you have proven a real CSF venous fistula, in my mind, the blood patch does not work. What you can try, you can do CT-guided fibrin patching. This is what in our department the radiologists do. So, but it's a targeted treatment. You go to the level where you know that your fistula is. Another option is neurointerventional treatment, like transvenous onyx embolization of the CSF venous fistula. Concerning the question, treating the fistula first or subdural, this is what I tried to answer in the last questions. If the subdural is symptomatic, then you have to treat the symptomatic and look for the fistula afterwards. If it's rather asymptomatic, you can treat the fistula at the beginning, go spinal first.
Another question, probably for Georgios. Where was it? Yeah. Is there any evidence that whether a ventricular or lumbar shunt is preferred in patients with IIH? Is there any numbers?
Yeah, there are studies. There has been a study from Birmingham published in 2011 that showed that LP shunts are very good at treating the papilledema, but they come with a high revision rate. And in Birmingham, we have changed from an LP shunt to a VP shunt many years ago, and we have seen better overall revision rates with VP shunts. And I think most of the literature suggests that VP shunts are probably better to LP shunts in IIH, but this is not backed up by high quality evidence. And my advice would be, whatever works in your hands and you are satisfied with your surgical results, then continue with that. But there is some suggestion that VP shunts are probably better.
Yeah.
So some more questions from the panel to each of you.
Susan, what do you think about the GLP-1 studies and for weight loss?
Yeah, so I actually had a few slides on the GLP-1 studies, because we're starting to hear that big data signal coming out of the TriNex, both the US and the global collaborative networks, which are very large databases of electronic health records. Now, we've got to remember that electronic health records, when you scale up, sometimes the coding isn't brilliant, but essentially there is a good signal to say that GLP-1 receptor agonists reduce the amount of medicines we need in IH, reduce the amount of headache. There's also there's one study showing a reduction in the requirement for surgery in terms of CSF diversion and stenting. So I think, the signal is there. I think when I think about weight management, we have to think about the individual, and GLP-1 receptor agonists may not be ideal for everyone. With all weight management sort of different avenues you go down, there are barriers to accessing care. And I think we're learning an awful lot more about the GLP-1 receptor agonists. On the other side of it was we published a small study, which was a phase 2, with ladies with telemetric ICP devices in, and we used a GLP-1 called exenatide, which is short-acting GLP-1, which actually currently isn't commercially available with AstraZeneca, but I believe there is a biosimilar now in the States. And that showed that our women had excellent reduction of their ICP at 24 hours all the way out to 3 months, and they didn't have weight loss. And I think what's interesting here is to understand that not all, although we have a family of medicines here, they obviously have differential actions in central nervous system. So I think, you know, we're going to learn so much more in the coming years, and I'm very excited, Rigmor, for the results of the IH dual study, which I hope you'll be bringing to us next year, maybe.
We're working on it. I heard good news today, so that's fine. But again, it is disease modifying and weight loss, and that's so different from the low pressure headaches that where surgery is absolutely or patching, targeted patching is the key. Here we have more mechanical. The other is is a much more complex disease, and we have to have the disease modifying underlying mechanism to understand. But there's so much to learn. So anyone has an animal model of low pressure headaches. We have the high pressure. Do we have and learn about the amplitude and all these things? Anyone that have them and aware of that? No? Georgios, you have any? No? But it should be fairly simple to have, but there's no orthostatic component in a rat with 4 legs.
And they do have a tail as well, so this is quite complicated. But I think there has been a Copenhagen group working at an animal model with Nana McAuley.
Yeah, not low pressure, but high pressure. We have also high pressure, but it's not a low pressure. And I think we could learn so much in that. Also, the whole physiology and what is rebound, and if we close the leak and so on. What's going on there in relation to Jürgen's question before? But I'm not aware of that.
I'm not aware of any model either, and we never will have the orthostatic component in any animal model that I'm aware of. So what is very, very intriguing is what you've mentioned earlier, and Susan mentioned that with the new telemetric devices, we will get a lot of new insights into CSF physiology and pathophysiology. And it is amazing if Susan reports that a GLP-1 agonist reduces ICP in 24 hours. So I mean, how? It's not weight loss then. And the normal values will shift probably a little bit. And data that I know from some groups that are doing it, that ICP is negative, not only in the beginning after standing up, as you thought, it continuously is negative. It's all the time negative. Now at the moment we're sitting, it's negative. So this is probably a huge new field, telemetric ICP in health and disease. I'm very curious what we are getting the numbers from.
Absolutely.
So if there are no more questions, this was a superb, cool, very interesting webinar. Do you have any final questions? So I start with the final comment. Thank you so much for preparing wonderful talks, wonderful slides, doing all the work, lovely discussion, and so thank you really very much, and the EANS for making this possible. And from my side, have a good afternoon or a good night. Bye-bye.
Thank you.
Thank you.
Thank you so much.
Bye.
Discussion. Let's carry on. Bye-bye.